Hello, my name is Kerri Jones and I'm about to present one example of how quality improvement methods can be applied in a partnership, in this case in two Kenyan hospitals. We've been posed several questions in how to address this, and I'll pick these up during the presentation if I may. By way of background, I've been working in Kenya with colleagues for over 10 years with several hospitals and communities on a variety of projects, and initially I participated as an anaesthetist. We formed a THET institutional partnership between Torbay Hospital in Devon and Nanyuki in Kenya, and formed a charity, Future Health Africa. We were able to obtain several DFID grants through the THET Health Partnership Scheme, but our initial focus on sick patients moved to looking at treating sick systems, and we were also concerned that at the end of the grant's lifetime, how we could leave behind skills that would allow the facility to improve on its own. So we became interested in how to achieve that. So the first question is why twinning partnerships might be effective in delivering interventions to improve quality of care. And I think the partnership placed us in a very good place to understand how to do this, because we had a deep understanding of the context through working together, and gave us the opportunity to bring together what are mostly people to make this happen. The frontline staff, patients, leaders, people who know how to apply QI tools, researchers, educators, those working on environmental sustainability, and in a position to look for in-country NGOs doing similar work, and potentially non-health players as well, for example from the business sector, because health is so dependent on economics. Internationally as well, the need to link quality of care to the universal health coverage agenda has now been recognised and highlighted in 3 big publications in 2018, which you'll see on this next slide and you can look at your own leisure. But it's in part important now that partnerships identify work going on around UHC, as it's such an important agenda now, and to link to it. And established partnerships are a good place to test these relationships. These are the 3 papers that you can look at later. So how have we used quality improvement tools in our setting? Well, to begin with, we established a queue for a Quality for All faculty to co-develop and test ways that we might be able to teach quality improvement and leadership. And to be clear about our definition of quality improvement, because there are many out there, we use a simple one, which is that it's a systematic approach to achieving better patient experience and outcomes. The format we arrived at is called the Springboard programme, and it's 2 5-day courses separated by a few months. The first 5 days is predominantly quality improvement with some leadership, and real QI projects are established during this first week. We then follow up with 5 days of predominantly leadership skills, but a bit more QI as well. We take 20 to 24 participants per programme of mixed cadre, gender and work background, chosen by the facility itself. And the participants identify pressing problems that they'd like to work on and set up 3 or 4 projects in teams. They learn the principles of quality alongside teamwork, culture for improvement, leadership and QI methodology, and they also get to see how their work will link to their own national quality agenda. In terms of methodology, we teach a blend of the Toyota lean methods and the Institute for Healthcare Improvement model for improvement, along with essential leadership skills. And as I said, the participating teams establish their own QI projects guided by our faculty and supported by an A3 worksheet on which the project can be recorded and the steps are made clear. And we leave them with workbooks so they have both the structure and knowledge base that they can reuse on future self-generated projects. The Toyota elements we touch on are 5S, Kaizen and TQM. We won't spend time on that. And this is a snapshot of our A3 worksheet adapted for our needs, in which we embed PDSA cycles. And this clear process and structure is needed, we think, because people tend to do the wrong things. We all do. We jump to solutions before understanding the problem, therefore put in the wrong solutions, then become disillusioned and carry burdens individually, whereas actually if we'd shared the problem with the team, we would have made better progress. The leadership skills we teach are those that are widely recognised as being useful for managing change, and here they are. I won't go through the list. And it's really helpful if you have good local leaders like Dr. Kilonzo, the medical superintendent here, who was both an excellent team player and leader and really supported us at the outset. So what have our results been? Well, here you see that complex skills can be really easily learned, and this is a young medical intern. This is on day 2 of a newly into the course that her team had produced this fantastic piece of work analysing a particular problem around resuscitation. So people were able to establish good QI projects, and this is a range of projects that have been established. They go from hand washing through to patient labelling, both WHO priorities, reducing injections, waiting times, communication, pain management, a great variety. So the format seems to have worked well, and we've had very positive feedback. We've delivered over 1,000 days of training to more than 100 individuals, and a formal evaluation showed that participants felt that the projects were very useful to patients and to staff, and 75% of them were successful. The participants were also very satisfied with the course, both in terms of knowledge and skills acquisition, although they would have liked it to have been longer. Each individual project has its own measures, and we can't go through all of those, but these are just some basic ones that show good improvement. So blending methodologies for us seems to allow us flexibility, and many methods can be used, but they must all cover the basics, which should be clear identification of the problem to be solved, good stakeholder analysis and engagement, analysis of the current state, what's the problem like now, and we teach a range of tools that can be used to look at that deeply. Then there needs to be a process of creating the future state with a clear goal, and then the development of interventions to move from now to the future using, for example, PDSA cycles or 5S strategies. We emphasise the need for measurement for improvement and that there will be barriers and challenges to tackle along the way. So has this training spread to other parts of the system? Well, we've found evidence locally in the two main hospitals where we've worked of other self-generated projects which were nothing to do with us, with some of them, although not all, using the methods taught. Other hospitals have adopted some of our ideas and solutions, apparently, and I have some evidence of that. And the course has gained national notice in Kenya, which has led to invitations to participate at every level in their emergent QI endeavours. Further spread, though, of these methods and teaching will depend on development of local faculty and QI coaches, which will need to be supported by ministers at county and national level. So what practical steps could other twinning partnerships take to apply? Well, simple things first, and a lot of success we find is all about people owning their own actions, attitudes and behaviours, and that putting in a nurturing approach to these takes you a long way. But QI tools are very widely available and are readily learned with a skilled facilitator. It's our strong belief leadership training should run alongside, and that the skills should be learned live and in the workplace, and joined up with environmental sustainability approaches where those are present. Engagement of senior management is really important because they will need to develop a local structure to support QI in an ongoing way and develop local faculty. Our work's been in hospitals to date, but we're going to be giving attention to community level QI very shortly. Just a reflection at this really difficult time of COVID-19, the whole experience is really reinforcing the need for improving quality of care across the globe. And it also shows that nothing happens without the engagement of the workforce, but when they do engage, they are totally brilliant and innovate on a daily basis and bring in new and imaginative ways of working, which we don't see in quieter times. So unfortunately, the impact will be terrible, but there will be much to learn, and the quality agenda will be well placed to support recovery of the health systems. And hopefully, health workers will be more valued by society and governments at the end of all of this, and it will be clear just how much health systems need urgent strengthening and integration, and how across the world we should and hopefully will continue to learn from and value each other in the journey towards better quality care. Thank you.